Thank you very much for the introduction, and thank you for giving me this opportunity to present our work at Laboratoire d'Imagerie Biomédicale. So today I'm going to talk about the contribution of spinal cord to disease aggressiveness. So as we may all know, ALS is a very progressive neurodegenerative disease affecting both upper motor neuron in the primary motor cortex, as well as lower motor neurons in the brainstem and the anterior horn of the spinal cord. But it's well recognized nowadays that we have also involvement of extramotor regions, particularly cognitive frontal regions. So the disease is very heterogeneous with variable phenotypes as shown in this figure. And with the different disease progression rates, well, we will have 1% of the patients will have up to 18 months of survival, and between 10 to 25% up to 5 years, and then between 5 to 15% more or less up to 10 years. And it's here we can see in this figure, we can see the progression of the decline of the ALS across time. And we can see clearly that depending, it's not working. Yeah, so depending on the individuals, we will have very different course of the disease. And there is an urgent need of biomarkers in ALS to stratify patients in order to evaluate the treatment efficiency, because in the clinical trials they are fail because they try molecules on very heterogeneous group of patients. So we need biomarkers to have more homogeneous patients. And the clinical trials still rely on survival, functional score, and respiratory measures, while for more than 2 decades now, imaging showed a potential good candidate for stratification in ALS. And here we can see MRI of the brain and spinal cord from one of my colleagues' studies. So in our lab, we are interested in spinal cord MRI, of course, because it's in ALS, because it's a key disease-defining site. It remains unstudied compared to the brain, despite the fact that it's offering a unique opportunity, unique window on capturing both upper motor neurons with the corticospinal tract and mainly corticospinal tract, and lower motor neurons degeneration with alpha motor neurons in the anterior horn of the spinal cord. The contribution of a spinal cord degeneration to disease aggressiveness is still far from being clarified, even though we have a few studies on this question. So the objectives of this study is to investigate the link between the cervical and upper thoracic spinal cord level atrophy and disease aggressiveness in ALS. So here we have our population. So we have 78 healthy controls, 93 ALS patients that we split it in 3 groups: slow progressors, intermediate, and fast progressors. We can see that the fast progressors, they have very short disease duration compared to the intermediate and slow. And also we have more motor impairment in fast compared to the other groups. And of course we have here the values of disease progression rates. So we split them based on the disease progression rates calculated with the ALS and disease duration. So for the MRI, so we used MRI's the T2 weighted image, 3D T2 weighted image, because it has very nice contrast and we can delineate different levels of the spinal cord easily. And we used MRIs coming from different studies, neuroimaging studies and centers. The first one is from the PULSE study that you all heard about yesterday. This is a national study And the MRI protocol was established by the CATI, trying to harmonize all the sequences between centers. And for this specific study, we used only data coming from Paris Center. We used also all the MRIs and coming from our previous studies in our lab, as well as a few MRIs coming from an open access MRI dataset. So for the processing part, so the MRI, spinal cord MRI images will go through a pipeline, which include denoising the image, normalizing the intensity, which is a part of harmonizing the data between the different centers, vertebral labeling and segmentation of the different levels of the spinal cord using the spinal cord toolbox and the deep learning tool of the spinal cord toolbox, deep seg. And then we computed the cross-sectional area between C1 level and T2 because these are the levels that were common between all the subjects. Here's the results of the comparisons between the different groups. So of course we found the classical difference between ALS and healthy controls, atrophy at all cervical and T1, T2 thoracic levels. When comparing the different ALS progressors, we show that slow progressors has significant cord atrophy only in the upper part of the cervical spinal cord, while the intermediate and the fast progressors, they have atrophy at all vertebral levels. Is the distribution of the different values of the cross-sectional area along the different vertebral levels in healthy controls ALS, as well as in healthy controls slow progressors, intermediate, and fast progressors from C1 to T2. Regarding the correlations, so we found a correlation, modest correlation between the ALSFRS and the spinal cord cross-sectional area at C6 here, C7, and T1 vertebral levels, and the cross-sectional area at C7 vertebral level correlated with the ALSFRS progression rate. So in conclusion, in our study we used, first of all, we used a large data set of MRIs. Usually in most of the studies we have a small data set, or the studies that will focus only on the upper cervical spinal cord, because they usually used MRIs with brain and spinal cord, so they don't have access to all large segments of the spinal cord. So from our results, we suggest that spinal cord atrophy might contribute to disease aggressiveness, especially at levels innervating the forearm and the hand muscles, the C7 vertebral level. So these findings, they extend the previous work that I did and other people did, by highlighting that the combination of upper motor neurons and lower motor neurons degeneration in specific regions of the nervous systems drives disease aggressiveness in ALS, and this would help understand the heterogeneity in the disease. So this study underscored the potential of spinal cord MRI and largely brain and spinal cord MRI as a complementary tool for clinical assessments for improving disease prognosis and patient stratification. So some perspectives of this study. So we will expand our analysis to a even larger data set coming from Pulse study, which and for a subset of these data, we will have individuals that had both brain and spinal cord MRI. In the lab, we have a lot of developments in ALS ALS and using MRI. So one is an AI-based that I'm developing with one of my colleagues, Clara Bremont. And also the development from Dmitry Todorov, the virtual brain and spine twins that you heard about yesterday at the gala. These two were, the first one was founded by Fondation des Maladies Rares, so Foundation of Rare Diseases, and the second one by ARSLA. Thank you very much. This will enable both group level analysis and especially individual analysis in ALS. My colleague Clara Bremont is developing AI-based lumbar spinal cord segmentation method. So this will enable us to investigate even a larger portion of the spinal cord, so the entire spine axis. And of course, our future investigation will be enriched with other analysis, especially quantifying, separating gray matter from white matter in the spine, and incorporating additional quantitative MRI measures coming from other techniques, such as diffusion tensor imaging that you heard about during this meeting, magnetization transfer that will quantify demyelination. This new technique that it's used a lot in the brain, but less in the spinal cord, quantitative T1 relaxation, T2, QSM to quantify iron content in the tissue. This will enable us to gain deeper insights in ALS pathology. And last, I would like to thank all the clinical coordinators of a pulse study, all the members of CATI for the MRI, multicentric MRI protocols, of course, the patients and their relatives, and finally, all the support from all these institutions, and particularly from ARSLA. Thank you very much.
So thank you for this very nice talk. We're still good in time, so we have time for some questions.
Thank you very much, and thank you for being really a leader in this field. I've been following your work on the spinal cord. It's really impressive. When you say that you found a correlation between C6 atrophy and the LSFRS, have you looked at the subscore, and would like the fine movement, for example, be more involved? Just to kind of differentiate, is it specific to upper extremity versus the whole kind of score?
Yes and no. So no, not specifically in this preliminary study, but we already published results on that in a couple of years ago, and we showed that cross-sectional area was correlated to the arm LSFRS and also correlated to the arm and leg manual muscle testing. This was a longitudinal study, and also predicted if I remember correctly, it predicted the arm and the total ASFRS 1 year later. So the baseline predicted the ASFRS 1 year later. But we found, of course, I did this analysis in the larger data set coming from Pulse, so integrating all the data from Pulse. And we have very interesting results, and hopefully we're going to show these results in NCALS or probably next year in JR12, if there's any.
Okay. Did you look at the parameters of the strength of the diaphragm and the ventilatory parameters? Did you make correlations?
So you mean all the respiratory parameters?
Yeah, all the respiratory and the parameters dedicated for the strength of the diaphragm.
So this work, I didn't, but this work was done by one of my colleagues, Hamayesa, who found a correlation between the brainstem volume and the spinal cord cross-sectional area with spirometry. So this is a mistake. So spirometry measure of the lung volume And he showed that the model incorporating clinical data and MRI data, so volumes from the brainstem and spinal cord, predicted the non-invasive ventilation 6 months after onset.
I know your paper,
already published.
Yes. Thank you very much for your presentation. Did you look at a putative correlation between the MRI of spinal cord and genetic defect in ALS? With
So
subgroup, with SOD1, with...
we don't have, in this study, we don't have enough genetic data. By the way, we didn't got from Pulse, we got the genetic data only this summer, so this was done a little bit before. But of course, I'm investigating this question in the entire data set, and we have, if I remember correctly, more than 30 subjects having the C9 mutation, and a few subjects having the SOD1 mutation. But yesterday, my colleagues, she presented what's in pre-symptomatic cases, the link between spinal cord MRI and the C9 mutation.